Thank you very much. I think you are very much exhausted, so I will simplify my presentation as much as I can. I promise you, I won't take too much time. So as you can see, we'll talk about trying to split my presentations into the dry eye before cataract surgery and dry eye after cataract surgery, which actually touch our everyday practice in ophthalmology, especially in the cataract surgery. So here, as you know, that the precorneal tear film is the most important refractive media of the human eye. And because now the tear film is just the first media that hits the light rays, and the light rays hits the precorneal tear film. And the biometry, when you are going to calculate the power of the lens, the biometry depends very much on the K readings, and the K readings is affected by the effect of the dry eye or the presence of dry eye, because K reading can only be accomplished by reflections, and for manual Ks as well as the optical biometers rely on shedding some images on the surface of the cornea, and if these images are blurry, the machine cannot detect the distance between those images and miscalculate the distance and miscalculate the power of the cornea, and this definitely will end up with ametropia after cataract surgery, and one diopter of measurement of the K readings result in one diopter of refractive error after cataract surgery and implantation of the lens. It's a nice study that shows that most of the patients coming for cataract surgery, they are asymptomatic and still have signs and symptoms of signs of dry eye. Up to 77% of those patients has positive corneal staining, and the tear film breakup time is less than 5% in 60% of those patients. And those elderly patients coming for cataract surgery, surprisingly, they are asymptomatic. So we have to look for dry eye, and this shed a light on the impact of the dry eye and the importance of dry eye before cataract surgery and before biometry as well. So another study shows that in patients with dry eye, you can see that there is a huge variation and increased repeatability, decreased repeatability of the K readings. And so you may miscalculate the amount of astigmatism on the level of the cornea as well as the axis of the astigmatism. And the repeatability as well, you can see, is much worse with the patients with dry eye. So this is an example to show you the before. This is before treatment of dry eye. This patient definitely has some corneal astigmatism, and probably we can assign this eye for toric IOL implantation. But after just few drops of lubricant, and the patient come back again for measurement of the K reading, and you can see here that there is no corneal astigmatism. So sometimes you may have misconception that this cornea has some astigmatism and may schedule the toric lens for this patient, and actually the patient has no corneal astigmatism, and it results in post-op ametropia and increased or reduced cylinder because of implanted toric lens in an eye that does not need a toric lens implantation. Again, you can see here, this is another example for a patient with before and after treatment of dry eye. You can see that the cornea, after 2 weeks of treatment of dry eye, the cornea has very much regular astigmatism compared to the preoperative values. So again, please, when you are going to screen for dry eye patients before cataract surgery, rely on reflection. So you have to look on the Placido disc device, not the tomography, not the pentacam, because the pentacam is not affected very much compared to the Placido disc. Placido disc shed some images on the cornea, and this can detect dry eye patients. So I personally perform the topography for all patients coming for cataract surgery, and I have a look on the Myers on the surface of the cornea to get an idea about the status of the cornea as a screening tool. And as you can see in those images, with the pentacam, you cannot detect the dry eye, but you can detect it even with the Placido disc. And you can see that they're very much irregular cornea. This is not an irregular cornea. This is actually because of dry eye. This can be hidden with the pentacam. So please, if you're going to screen your patients for dry eye, depend on Placido disc device, not the Scheimpflug imaging device. What about the dry eye after cataract surgery? I will show you a couple of cases, my cases. This case number 1, 64 years old lady coming for complaining of dry eye symptoms that has been worsening after cataract surgery. She did the cataract surgery 1.5 years back, and she is complaining of burning sensation, itching, photophobia, etc. And the visual acuity was pretty well, 1 in both eyes, and the refraction was almost emmetropia. And she denied any symptoms of dry eye before cataract surgery. And she blamed the surgeon and blamed the surgery on her worsening condition of the dry eye. And she tried several lubricating eye drops, but there is no improvement. And she's asking for help. And here, so definitely we can have some patients that we did all our job and the patient is not satisfied. We did perfect refraction, perfect biometry, perfect surgery, but still the patient is complaining because of the dry eye. So this clinical examination of the patient showed no fluorescein staining, decreased tear film breakup time, some mild conjunctival hyperemia, no scars, but I need more data. So I put the patient in front of the tear film analysis with the CSO, and you can see there is reduced tear film meniscus height. And we need here an objective measurement and trying to convince the patient that she has a problem with a dry eye. There is a decreased meniscus height here, and the breakup time here is very much low. It's around 3.9 seconds. So this may explain, of course, the patient worsening the condition, the fluctuation of the visual quality, as well as the symptoms of the patients of increased photophobia. And I took the patient on front of the slit lamp for the second time because now I have an objective measurement of the tear film breakup time, and I tried to convince the patient there is something wrong with her eyes. So I just put the patient in front of the slit lamp with high magnification, and you see, what is this? Demodex. The patient has Demodex. And this is explained the blepharitis and the dry eye the patient was complaining of. So you can see that Demodex is characterized by the cylindrical dandruff and telangiectasias in the lid margin. And this is actually an obligatory ectoparasite that presents in all our lids and skins, but maybe overpopulation in some elderly patients, especially before or after cataract surgery. I tried in the literature to find a relation between the Demodex and cataract surgery. And actually, Demodex infestation is very common in the elderly patient, which is almost the same age as the patient coming for cataract surgery. And again, after the cataract surgery, probably because of the disturbed immunity or because of the topical use of steroids, I have only one paper relates the Demodex infestation increased after cataract surgery, and they proposed because of the steroid use after cataract surgery. So anyhow, we have to suspect Demodex in patients coming for cataract surgery before and after. And if the patient is complaining of dry eye symptoms exaggerated after cataract surgery, we have to prove this for the patients by taking some objective measurements by tear film analysis or dry eye report of the MS39. And then we can convince the patient that this is not an actual treatment of eye drops. We need to do some other measures like the Blefex, microexfoliation, or do some LipiFlow or intense pulse lights. So this patient has been subjected not only for lubricant eye drops, now she was convinced that she needs another adjuvant therapy in the form of intense pulse light and tea tree oil, wet wipes, as well as mechanical exfoliation, which is not commercially as Blefex. So you can see here the improvement after the treatment, and the patient now has improved visual quality, improved lifestyle, and now she stopped blaming the cataract surgery and stopped blaming the surgeon, the previous surgeon, for reduced her visual quality and quality of life. You can see here that the meniscus height improved from 0.15 microns to 0.22 microns, and this is a comparison between before and after treatment on the MS39. So this is another case. Another lady, 56 years old, complaining of blurring of vision after cataract surgery done 4 months back. And the patient is complaining of nighttime halos and glare and occasional sense of dryness. Her main complaint about the bad quality of vision after trifocal IOL implantation. She was assigned for trifocal IOL implantation, and you can see that the visual acuity was not very good. 0.8 in the right eye, 0.7 in the left eye, and there are some sort of refractive astigmatism in both eyes. And she was on lubricating eye drops without any benefits, 3 to 4 times per day without any benefits. And she was referred by her doctor just for explantation of these lenses with another monofocal lenses. So I sit with the patients and just examine the patient. You can see here just before, with the compression of the lids You can see expression here. You can see the greasy substance on the ocular surface and the toothpaste-like substance coming from the orifices of the meibomian gland. This is definitely a diagnosis of meibomian gland dysfunction, although she had a negative fluorescein stain. And this is what you see on slit lamp, just telangiectasias. The orifices are blocked by toothpaste-like creamy substance, and you can see a lot of greasy material in front of the corneal surface, and that's why the patient is complaining of bad quality of vision on top of the trifocal IOL implanted in her eyes. And there is, of course, a close relation between the dry eye and meibomian gland dysfunction. Dry eye can induce meibomian gland dysfunction, and meibomian gland dysfunction induce dry eye, and both are coming together, interacting in a vicious circle and leads to each other. So, of course, again, the relation between dry eye and cataract surgery. The cataract surgery can induce dry eye and exaggerate pre-existing dry eye because of the dilating eye drops, because of the copious irrigation during cataract surgery, because of the cutting of the corneal nerves, because of the association with astigmatic keratotomies. I'm pretty sure that you are all aware about the relationship between the cataract surgery and the dry eye. So here, as you can see here, with the quality of vision, you can see here, this is the topography, and you can see that the disturbed Myers, the Myers is a screening tool. It's a very nice, pretty nice tool to see that the reflections are not regular here. And you can see that the cornea, her cornea is not very much regular, not because of the irregularities or because of the opacities, but because of the dry eye. Here, this is the simulation of the quality of vision, and this explains why this patient is not happy about her visual acuity and visual quality, because of the induced aberrations because of the dry eye. So, and this is another dry eye report. You can see that the ocular redness, and meibomian glands, tear meniscus, and fluorescein breakup time. And you can see you have reports for right and left eye that confirms in an objective way the presence of dry eye. And you can see now here, I sat with the patient and okay, I tried to convince the patient it's not necessary to explant this lens and substitute with another monofocal lenses, but probably we can give it a try to treat the dry eye before taking the decision to explant those lenses outside the eye. So I started with an aggressive treatment of meibomian gland dysfunction, and I said to the patient, told her that management is multifactorial. It will not be just only eye drops, and it might take several months until we reach the end of the treatment of the dry eye. And then if the patient is not satisfied after treatment of dry eye, we'll go for taking these lenses outside. So as you can see here, after treatment, the treatment was just short course of topical steroids, tear substitutes, oral medications like doxycycline, and topical cyclosporine, and lifitegrast as well. And I scheduled the patient for 2 sessions of LipiFlow at 6 months apart. And you know, that's vector thermal pulsations, trying to remove the block of the meibomian gland by thermal pulsations, as well as pressure into the meibomian glands. We can treat the 4 lids altogether in a session of 12 minutes, and then we can repeat it maybe after 6 months if necessary. So as you can see now, this is before treatment, 6 months, and this is after treatment of the meibomian gland dysfunction. This is before and this is after. You can appreciate the improvement not only on the symptoms of the patient in terms of dry eye, and you can have a report to compare pre and post. You can see reduction in everything, reduction in or improvement, let's say, in the tear meniscus height, improvement in the OSD questionnaire, improvement in the redness of the patients, as well as the meibomian gland dysfunction. And you can see here, this is tracking. I keep tracking of the patients regards the topography as well as the visual quality. You can see that the Myers are getting better every time. And in the right side of the screen, you can see that now the Myers are much more regular, and the topography itself, it's much more regular compared to the first one in the left side of the screen before starting the treatment. And this is again the comparison of the higher order aberrations. You can see the higher order aberrations has been pretty much improved on the level of the cornea compared to the pre-treatment values. And this is again simulated visual quality of the patients. Now the visual quality improved on the level of the cornea before and after treatment. So finally, we have a satisfied patient, and the patient did not want for explantation, and she preferred to keep her trifocal lenses, enjoying near and distance visions as well as intermediate vision, because if we just rushed into explanting this lens, probably the patient won't be satisfied because we didn't treat her previous or original issue, which was the dry eye, meibomian gland dysfunction. So very much important to have a tool to objectively measure and tracking your patients regards the dry eye before cataract and refractive surgery, and keep tracking those patients and trying to have some objective measurement to just convince your patient that the patient might need another tool for treatment of dry eye other than the eye drops. Thank you very much for your attention.